welcome to the deep dive. Today we're stepping away from the aorta, the big one, and looking at all the other places stents and stent grafts get used.
Yeah, the non-aortic world. It's pretty vast when you think about it.
We're digging into Chapter 69 of Rutherford's 10th edition Non-Aortic Stents and Stent Grafts. The goal here is really to understand how surgeons pick the right device for, well, everywhere else in the body.
Right. It's not just a one-size-fits-all situation. There are a lot of factors that go into that decision. Arteries, veins, different locations, different problems.
Exactly. So think of this as your shortcut. Through some pretty complex stuff, we'll be pulling out the key ideas from the chapter.
We'll touch on, how stents even started, how they interact with blood vessels. That's crucial.
And the different types, obviously. What makes them tick, why choose one over another.
Plus, what happens when things go wrong? Failure modes, and then look at the newer stuff like absorbable stents and maybe where things are heading.
So if you've ever wondered how that choice is made, this tiny mesh tube versus that covered one, and why it matters for how well things go, both right away and down the line, well, this is for you.
We'll try and break down the technical bits into something more digestible.
Okay, let's rewind a bit. The chapter starts with the history, before stents were even really a thing. Angioplasty.
Yeah, Daughter and Judkins back in '64, then Grinzig with the balloons in the '70s. It was revolutionary, just pushing the blockage open.
But it wasn't perfect, was it? The chapter highlights some major headaches.
Oh, definitely. You'd open the vessel up and bam, it could snap shut again. Elastic recoil, they call it.
Or vasospasm, where the plaque itself could rupture, or you could get these tears.
Yeah.
Dissections.
Right. And even if you got past that, the re-narrowing, the restenosis, was a huge problem. The body's healing response was just too aggressive.
How aggressive are we talking?
Well, the numbers are pretty stark. For coronary angioplasty, the chapter mentions restenosis in like 30 to 50% of cases.
Wow, that's almost a coin toss.
Pretty much. And similar failure rates, sometimes hitting 50%. In renal, iliac, leg arteries too. It really limited how useful angioplasty was compared to surgery back then.
So clearly, just pushing it open wasn't enough long-term. Enter the stent.
Exactly. The stent was the answer, or an answer anyway. Provide some scaffolding, right? Keep the vessel propped open, keep blood flowing.
And maybe stop debris from breaking loose.
That was part of the idea too. Mechanically support it, but like the chapter points out, it's a double-edged sword.
How so?
Well, you solved the recoil problem, but now you've put this foreign object in the vessel, and the body reacts to that. It disrupts the normal healing process.
So you trade one set of problems for another, potentially.
Sort of, yeah. It leads to its own challenges. The interaction between the stent and the vessel wall is really key.
Okay, let's dive into that interaction. It's a two-way street, you said.
Right.
How does the vessel react to the stent first?
Well, the amount of injury you cause when putting the stent in seems directly linked to how much tissue overgrowth you get later.
Injury meaning?
Physical damage to the inner lining, the endothelium. The chapter mentions an experiment, I think, in pigs, where stents designed to push deeper into the wall caused way more neointimal formation. That's the tissue overgrowth.
More initial damage equals more aggressive healing response.
Seems that way. And it's not just the physical damage, there's inflammation too. The body sees the stent material as foreign.
Like an immune response.
Kind of, yeah.
Yeah.
Inflammatory cells hang around the stent struts for months, and apparently even microscopic contamination during the procedure can add to that tissue growth.
It's incredibly sensitive. Now, what about the blood flow itself? How does this stent change things there?
That's the other side of the coin, fluid dynamics. Stents change the flow patterns. A big factor is creating areas of low wall shear stress, or WSS.
WSS, wall shear stress.
Yeah.
That's like the friction of the blood against the wall.
Exactly. And too little friction, low WSS, seems to be a bad thing. It actually encourages that tissue overgrowth and re-narrowing.
So how does the stent create low shear stress?
If you oversize the stent too much, expand it beyond the natural vessel diameter, you create pockets where the flow is sluggish near the wall. Models showed that overexpanding by just 20% could massively increase the area exposed to low WSS compared to, say, 10% oversizing.
So that's why surgeons aim for that specific 10% oversizing in the legs.
Yeah.
It's a balancing act.
Precisely. Enough expansion for good placement, but not so much that you mess up the shear stress too badly.
And even tiny details matter, right? Those stent struts.
Absolutely. Even the height of those little metal bits. The areas right next to the struts get altered flow. Studies suggest thinner struts, lower profile stents might lead to less restenosis.
And the pattern they make, how much metal covers the wall.
That all plays a role too. It's complex.
And finally, the materials themselves. Stainless steel, Nitinol.
Cobalt, chromium, tantalum. The chapter mentions that these can actually corrode inside the body.
Corrode.
Yeah.
Seriously.
Yep. And you can even get allergic reactions to the metals in some people. Or even, get this, electrical currents forming between the stent and the artery wall, leading to corrosion.
Wow. Okay, so this stent-vessel relationship is definitely not simple. There's a lot going on.
It really is.
So keeping all that in mind, let's talk about the actual devices. The chapter describes the ideal stent first. What would that look like?
The wish list. Easy to deliver, easy to see on X-ray, fits the vessel perfectly, stops recoil, doesn't cause restenosis, and never, ever breaks.
The unicorn stent. Okay, back to reality. Two main categories.
Yep. Self-expanding, or SE, and balloon expandable, or BE. Different materials, different ways they open up.
Let's compare them. Radial force, the outward push.
BE stents generally have higher radial force. They really push outward strongly right away, which is great for plastering down plaque or dissection flaps.
And SE stents?
Lower initial force, but it can increase as the stent gets embedded in the wall over time.
Okay, what about flexibility? That seems crucial for navigating bends.
Big difference here. SE stents are way more flexible, much better for getting around corners in twisty vessels.
Whereas BE stents are stiffer.
Much stiffer. They're mounted on a balloon, remember? They don't bend well and can even get squashed or deformed in arteries that move a lot.
Delivery, any differences there?
Usually, yeah. BE stents often need a guiding sheath pushed past the blockage first. SE stents might not need that sheath to go quite as far.
Visibility on X-ray? For placement?
BE stents, often stainless steel, tend to show up better than nitinol SE stents, so potentially easier to place precisely.
And oversizing. We talked about that 10% target.
Right. For SE stents, you generally want some oversizing so they properly contact the wall when they spring open. For BE stents, you generally avoid aggressive oversizing because it can weaken the stent structure.
Got it. What if the vessel isn't the same diameter all the way along?
SE stents handle that better. They can adapt to tapering vessels more easily.
And resisting outside squishing, like from muscles.
SE stents tend to be better at resisting that external compression too, more bounce back.
Okay, so a clear trade-off. BE for force and precision. SE for flexibility and adaptability.
That's a good summary.
Yeah. Now, within the stent mesh itself, there's this idea of cell design. Open versus closed.
Right, the pattern of the gaps. Closed cell stents have small, connected gaps, like a fine mesh.
Benefits.
More uniform wall coverage may be better at trapping debris so it doesn't float downstream embolization.
Downside.
Less flexible because it's all interconnected.
An open cell. Like a chain link fence, you said.
Exactly. Larger gaps, less connected, much more flexible, conforms better to vessel shapes.
Right.
But more of the vessel wall is exposed between the struts and maybe a slightly higher risk of debris escaping during deployment.
So which one do surgeons choose?
It often comes down to location and, honestly, physician preference. The chapter says there isn't really definitive proof one is always better. One study hinted closed cell might be better for carotids, reducing stroke, but a bigger study didn't back that up.
Interesting. So it's still debated. Let's dig into the balloon expandable ones a bit more. Best for high force, high precision spots. Any delivery challenges?
Yeah, because they're stiff, getting them there can be tricky. Risk of knocking the stent off the balloon on the way. That's why you usually use a guiding sheath advanced past the lesion and a stiff wire.
And they just expand to the balloon size.
Yep. You can post-dilate with the same balloon if needed, but using a much bigger balloon to overexpand them is risky, can weaken the metal structure.
But their big plus is that they deploy exactly where you inflate the balloon.
Absolutely. Minimal movement. Perfect for lesions right at the origin of major vessels, renal, iliac, subclavian, where you need pinpoint accuracy.
But not great for areas that bend a lot, like behind the knee.
Definitely not. Too much risk of fracture or getting kinked.
Okay, now self-expanding stents. The flexible option for twisty paths. How's deployment different?
They come compressed inside an outer sheath. You pull back the sheath, and the stent springs open to its predetermined size.
Sounds simple, but...
Requires careful technique. It's easy to accidentally push the stent forward or pull it back as you retract the sheath, leading to misplacement.
And you have to get the size right from the start because you can't really expand them further.
Right. Adequate oversizing is key so they sit snugly against the wall, if you undersize it. Well, the chapter mentions sometimes you can put a BE stent inside the SE stent to push it open more.
A little bailout technique.
Okay.
What about the third type stent grafts, or covered stents?
These are basically stents, either BE or SE, wrapped in fabric like polyester or PTFE. Think of it as the ultimate closed cell stent, completely seals off the vessel wall from the blood flow.
Why would you want to do that?
Main reason is to exclude problems in the vessel wall, like aneurysms, bulges, or fistulas, abnormal connections. Pseudoaneurysms, unstable plaque that might break off, even holes or perforations in the vessel, the cover seals it off.
And traps debris too, presumably.
Yes, that's another advantage, potentially reducing embolization risk during the procedure.
Sounds very useful.
Yeah.
Any downsides?
The big one is side branches. The fabric covers everything, so if you need to keep flow going into important side branches, a covered stent is usually not the right choice.
Like in the leg, maybe?
Exactly. The chapter mentions using them for long blockages in the leg artery, the SFA, where they might prevent emboli and tissue growth, sometimes working as well as bypass surgery, but if that covered stent clots off, you might lose flow to critical side branches and make things worse.
Right. A critical consideration. Depends heavily on the specific anatomy.
Very much so.
Okay, that sets the stage for how surgeons actually choose. The chapter outlines several factors. First, plaque morphology, the nature of the blockage itself.
Yeah, if the plaque looks really unstable or likely to break apart, you might see that on ultrasound or CT sometimes. Then a covered stent or maybe a closed cell bare stent is often preferred to try and contain that debris.
Like putting a lid on it.
Kind of. Covered stents are also good if you suspect there's fresh clot involved.
And if you don't use a covered stent, but you're still worried about debris.
Then you might use an embolic protection device, like a little filter basket downstream, to catch anything that breaks loose. Or sometimes even open surgery to flush things out.
Makes sense. What about external forces? How does that influence the choice?
Where the artery is located matters hugely. Think about arteries near the collarbone or in the neck. They can get squeezed by muscles or bones during movement.
So you need something that can withstand that.
Exactly. SE stents, being more flexible and resistant to compression, are usually the go-to choice in those mobile areas to avoid getting crushed or kinked. A stiff B stent just wouldn't hold up well there.
Okay, now for the specific locations. The chapter goes through quite a few examples. Let's start up high in the abdomen, the celiac artery.
Right, supplying the stomach, liver, spleen. Blockages there are often treated with BE stents. You usually deploy it extending just a tiny bit back into the aorta. Good long-term results generally.
Unless
the blockage isn't plaque, but compression from a ligament, the median arcuate ligament. Stenting doesn't fix that. You usually need surgery to release the ligament.
Okay, moving down to the SMA and renal arteries, supplying the intestines and kidneys.
Similar story for blockages right at the origin, where they branch off the aorta. Often plaque extending from the aorta, so BE stents are common for their radial strength and precision. Covered BE stents might offer extra protection against debris breaking off.
And further down those arteries, away from the origin.
Then SE stents might be better, especially if there's a tear or dissection. Sometimes, for smaller vessels way downstream, just balloon angioplasty without a stent might be enough.
Now, a common one in veins, May-Thurner syndrome, left iliac vein compression.
Yeah, the right iliac artery squashes the left iliac vein against the spine, can cause swelling or clots. If you treat a clot and find this underlying compression, you usually treat it.
With what?
Typically a large diameter, oversized bare metal SE stent. You need the strong outward push, and oversizing helps anchor it. BE stents are generally avoided in veins higher risk of poking a hole.
Got it. Let's move down to the leg's distal aorta and iliac arteries. Common spot for trouble causing leg pain.
Very common. For blockages right where the aorta splits, you often use the kissing stent technique, putting stents in both iliacs at the same time to keep the split open.
Covered or bare metal here?
Studies, like the COBEST trial mentioned in the chapter, suggest covered BE stents might last longer than bare metal ones here, especially for tougher blockages.
BE or SE in the iliacs generally.
It varies. BE often for short blockages, SE for longer ones, especially if they go down into the external iliac artery, which tends to be more twisty.
Is endovascular catching up to surgery for these big iliac blockages?
It seems like it. Modern techniques, including covered SE stents going right down into the top of the thigh, are showing pretty good long-term results now, challenging the traditional surgical approach.
What about below the groin, infranguinal arteries?
Generally SE stents territory down there, except for the common femoral artery right at the groin crease.
Why avoid stenting there?
Two big reasons. You might block off the profunda femoris artery, which is critical for thigh circulation, and it's a key access site for lots of other procedures, so surgery is often preferred there.
And further down the leg, like the SFA or popliteal.
Stenting there is usually reserved for when balloon angioplasty alone doesn't work well or fails quickly. The long-term results aren't always better than just angioplasty.
Okay, one more specific location. Dialysis access veins.
Ah, yes, the outflow tracts. Blockages are really common there because of the high flow and turbulence from the fistula or graft.
What works best?
Stenting the veins near the collarbone and upper arm seems to help the access last longer than just angioplasty. Large SE stents are usually recommended because these areas move a lot.
Covered stents useful here.
Potentially, yeah. Since the main problem is tissue overgrowth, stent grafts are a reasonable choice, especially if the vein gets damaged during angioplasty. Some studies show they outperform bare metal stents for certain blockages, particularly right where an artificial graft connects to the vein.
Okay, a lot depends on the exact spot. The last selection factor was branch location. What's the key point there?
When a blockage is right at the opening, the ostium of a branch vessel, like the renal artery origin we mentioned, the plaque often extends back into the main artery, the aorta in this case.
So you need a stent that can handle that.
Exactly. A BE stent is often best here. You get the radial force and the precision to cover the plaque in the branch and maybe slightly into the aorta, ensuring you treat the whole disease segment accurately.
Makes sense. Okay, we know how they're chosen, but things can still go wrong. Failure modes. Let's start with a big one. Neointimal hyperplasia and restenosis.
Right, that excessive healing response again. The body sees the stent, gets inflamed, smooth muscle cells multiply, and you get this tissue overgrowth neointimal hyperplasia that can re-narrow or even block the stent.
It's the body trying to heal but going overboard.
Pretty much, it's a constant battle.
And the stent itself can fail, right?
Yeah.
Fracture or corrosion.
Yep. They're metal under constant stress from the heartbeat. They can fatigue and break, especially in areas with a lot of bending or twisting.
Like where SE stents are often used.
That's the irony, yeah. Their flexibility makes them good for those spots, but also perhaps more prone to fracture over time. Overlapping stents seem particularly vulnerable.
So using longer stents to avoid overlap helps.
That's the idea. And corrosion, as we mentioned, can happen too, influenced by the environment, forces, even different metals interacting if stents overlap. Sometimes a covered stent is placed inside an overlap zone to try and prevent that, and these stents can leach metal ions, which might irritate the vessel wall.
Okay, so to fight that tissue overgrowth, we got drug-eluting stents, DESS, but the chapter calls them a double-edged sword. Why?
Well, they release drugs, paclitaxel, sirolimus, everolimus, that are really good at stopping that neointimal hyperplasia. They definitely improved results, especially in the heart. But the drugs can also delay or prevent the stent struts from getting fully covered by the vessel's natural lining. This leaves exposed metal, which increases the risk of a blood clot forming inside the stent, sometimes months or even years later, late stent thrombosis.
And that requires longer blood thinner medication.
Exactly. Prolonged antiplatelet therapy is needed. And while a clot in a leg stent is bad, a clot in a coronary stent can be catastrophic, right? So the stakes differ.
How have DS performed in peripheral arteries, like the legs?
It's been more mixed. Initial studies in the SFA didn't show a huge benefit over bare metal stents. Some newer paclitaxel-coated stents looked better, but then that meta-analysis raised safety concerns about paclitaxel, suggesting a possible link to increased mortality.
Has that been resolved?
Subsequent studies have cast doubt on that finding, but it definitely led to more caution. The chapter stresses discussing potential risks with patients.
So if a stent does re-narrow in stent restenosis, what are the treatment options?
It's a growing problem. Options include just doing balloon angioplasty again, maybe putting another stent inside the first one, using devices to physically remove the overgrown tissue that's atherectomy, or using drug-coated balloons or drug-eluting stents.
Any standout approaches?
Laser atherectomy followed by angioplasty showed better results than just angioplasty for bare metal stent restenosis in the legs. Drug-coated balloons also seem better than plain balloons. For really tough, long in-stent restenosis, putting a covered stent inside seems promising.
Always evolving. Okay, let's look ahead. New horizons. Absorbable stents.
Yeah, bioabsorbable scaffolds. The idea is great. Provide support while the vessel heals, then disappear, avoiding long-term implant issues.
How are they doing?
Early results in coronary arteries were okay, reducing tissue growth. But in peripheral arteries, especially the leg, the results have been kind of disappointing so far. Some early ones actually had lower patency rates than standard stents. One coronary version was even pulled from the market.
So, not quite ready for prime time in the legs yet.
Not quite. Newer materials, like magnesium, and adding drug-eluting capabilities to these absorbable scaffolds are being tested. They show promise, but haven't yet beaten standard therapy long-term in the legs, according to the chapter. More work needed there.
And beyond absorbable stents, what else is on the horizon?
Well, the field keeps moving fast. Maybe more refined devices, better techniques. Combining plaque removal with drug delivery is already happening. Perhaps eventually things like stem cell or gene therapy could offer totally new ways to manage vessel disease, maybe making stents less necessary in some cases.
Fascinating. So we've covered a lot of ground today, from the early days of angioplasty right up to these future possibilities for non-aortic stents.
Yeah, hopefully you have a better sense now of the different types, why one might be chosen over another based on the plaque, the location, the forces involved. It's a complex decision tree.
And that interplay between the device, the vessel wall, and the blood flow itself is just critical. Ongoing research is constantly tweaking things.
Absolutely. And it makes you think, doesn't it? What is the perfect vascular intervention? Stents were a huge leap, but maybe the future lies in therapies that work with the body's healing processes without leaving permanent hardware behind.
That's a really interesting thought to leave people with. What breakthroughs might truly change the game next?
Time will tell.
If you want to dig even deeper, check out Rutherford's, or look up recent papers on stent tech or bioabsorbables. Knowing more helps you have better conversations about your own health. Thanks for diving deep with us today.